Hello and welcome to today's edition of GPnotebook podcasts. My name is Dr. Hannah Rosa. I'm a GP working in the northeast of England and a member of the GPnotebook education team. Join us for a whole range of bite-sized topics tailored for those working in primary care, perfect for your daily commute or when you're out on a morning stroll. You can tune in to us on all leading podcast platforms and don't forget to like and subscribe so you don't miss an episode. And if you enjoy what you hear, please consider leaving a review. You can stay connected with us on X at GPnotebook for podcast updates and much more. Lastly, check out the new GPnotebook website for podcast show notes with additional resources and to register for study groups. In this episode, I'm going to explore hypercalcemia. Hypercalcemia is defined as a serum calcium concentration of 2.6 millimoles per litre or more on 2 occasions, following adjustment for the serum albumin concentration. It's important to identify hypercalcemia as it can lead to acute and chronic effects on cardiac tissue, the renal system, and bone health. The prevalence of hypercalcemia in the general population is approximately 1 to 2%. It is more common in older adults, with prevalence increasing with age. It is 2 to 3 times more common in women than men, and around 20% of people with malignancy will be affected by hypercalcemia at some point in the course of their illness. To explore how to manage hypercalcemia in a clinical context, we are going to break it down into 5 steps. Number 1, when we should consider offering a calcium blood test. 2, different actions to take depending on how high calcium is. 3, looking for an underlying cause in primary care. 4, next steps in secondary care. And 5, follow-up in primary care. So, step 1. When should we consider offering a calcium blood test? Now, here just ask yourself, what sorts of presentations prompt you to consider checking a calcium level? To answer this question, let's look at all the different ways hypercalcemia can present. Often, it will be an incidental finding on a blood test, and a patient may be asymptomatic, but it can also present symptomatically or with a complication that it can cause. From your medical training, you may all recall the aid memoir, stones, bones, groans, moans, thrones, and psychiatric overtones. Stones stands for renal stones, but it can also cause nephrocalcinosis, a condition in which calcium salts build up in the kidney's tubules and parenchyma, and renal failure. If a patient is suffering with recurrent UTIs, then this could be linked to bladder stones caused by a high calcium level. Bones, for bone pain and osteoporosis. If a patient has chronic back pain or has sustained a low-impact fracture, this could be linked with hypercalcemia. Groans, for abdominal pain, which can be due to pancreatitis or reflux disease, and it can also cause constipation, nausea, and weight loss. Moans due to fatigue, muscle weakness, irritability, worsening concentration, worsening short-term memory, and brain fog. Thrones is for polyuria, polydipsia, and dehydration due to nephrogenic diabetes insipidus. Psychiatric overtones, as it can cause depression, anxiety, and psychosis. And also remember that hypercalcemia can affect cardiac tissue, and so you can also get cardiac symptoms, including syncope, arrhythmias, and as the severity of hypercalcemia progresses, QT shortening, which can potentially lead to ventricular fibrillation. Given that, as you can see, hypercalcemia can present in so many different ways, we should consider measuring a serum calcium for people with chronic non-differentiated symptoms. For example, fatigue, mild confusion, bone, muscle or joint pain, anxiety, irritability, low mood, apathy, insomnia, frequent urination, increased thirst, and digestive problems. And so, I would argue that we should have a low threshold for checking calcium levels in primary care. Step 2 now focuses on the different actions we should take depending on how high the calcium is. If, for example, a patient is well but has a serum corrected calcium of 3.1, what would be your next steps? Well, hypercalcemia can be classified into mild, if it's between 2.6 to 3, moderate, if it's between 3 and 3.5, and severe, if it's over 3.5. If it is safe to do so, then ideally you would want to repeat the test to confirm hypercalcemia, which by definition is a raised corrected serum calcium on 2 occasions. When repeating the test, try to avoid prolonged application of the tourniquet during venipuncture to avoid pseudo-hypercalcemia. If the initial blood test suggests mild hypercalcemia and the patient is asymptomatic or has mild symptoms, then we should repeat the calcium level after a week to confirm the diagnosis. If the initial blood test suggests moderate hypercalcemia and there are no symptoms and the patient does not have a known or suspected malignancy, then we should repeat the calcium level within a week, but liaise with the on-call endocrinology team if we are uncertain. If the initial blood test shows moderate hypercalcemia and symptoms are present, or if the patient has a known malignancy, then we should arrange a repeat test in an urgent time frame, but we should have a low threshold for admission, especially if the patient is dehydrated or confused, and contact a specialist team if uncertain. If the repeat test shows moderate hypercalcemia or the patient is symptomatic, we should consider immediate same-day referral to hospital and/or liaise with the appropriate specialist. If the initial blood test or the repeat blood test suggests severe hypercalcemia or the patient has severe symptoms, then we should arrange an emergency hospital admission for further assessment and management. Step 3. If the patient can safely be managed in primary care, our next job is to look for an underlying cause. The most common cause of hypercalcemia is primary hyperparathyroidism. Primary hyperparathyroidism causes a calcium level of 2.5 or more. So note here, you can have primary hyperparathyroidism with a calcium which is at the top end of normal. And the raised calcium occurs alongside high or inappropriately normal parathyroid hormone or PTH. Calcium and parathyroid hormone share an inverse relationship, meaning that when everything is working normally, the higher calcium goes, the lower PTH should be. In primary hyperparathyroidism, this feedback loop is broken, usually due to a solitary parathyroid adenoma producing PTH. Other causes of hypercalcemia include tertiary hyperparathyroidism. Now, to understand tertiary hyperparathyroidism, you first need to understand secondary hyperparathyroidism. Secondary hyperparathyroidism is a condition where the parathyroid glands produce too much parathyroid hormone in response to low blood calcium levels. Tertiary hyperparathyroidism can then follow due to parathyroid hyperplasia from chronic overstimulation, which then results in elevated levels of calcium and high levels of parathyroid hormone. This is most often seen in patients with renal failure or a history of a renal transplant. Another cause of hypercalcemia is familial hypocalciuric hypercalcemia. This condition causes the body's calcium receptors to be blunted to the presence of calcium, mistaking normal calcium levels for being too low, and so PTH gets released. This is usually a benign condition that doesn't require treatment unless symptoms or severe hypercalcemia develop. The second most common cause of hypercalcemia is hypercalcemia of malignancy, which is non-parathyroid hormone mediated. With hypercalcemia of malignancy, PTH levels are appropriately suppressed or undetectable in the presence of a raised serum calcium. The malignancies most associated with hypercalcemia include leukemia, multiple myeloma, lung cancer, and breast cancer. A raised calcium can occur due to either a paraneoplastic syndrome, primarily through the tumour secreting a parathyroid hormone-related protein, or from bone metastases. Hypercalcemia of malignancy tends to present with severe hypercalcemia and significant symptoms and signs, often as an emergency. And it is a negative prognostic factor. It is key to suspect it when a patient with advanced cancer deteriorates suddenly. Medications can also cause or contribute towards hypercalcemia, including lithium, anabolic agents used to treat osteoporosis, thiazide diuretics, vitamin D or vitamin A supplements, or excessive use of calcium carbonate for treating dyspepsia or osteoporosis. Other conditions which have been linked to hypercalcemia include granulomatous diseases such as sarcoidosis and tuberculosis, and endocrine conditions including hyperthyroidism, pheochromocytoma, and adrenal insufficiency, and also immobility, which can cause hypercalcemia due to accelerated bone breakdown. And just be aware that more than one underlying condition may coexist, especially in elderly patients. When the cause of hypercalcemia is unknown, then we should review the history to check for symptoms of hypercalcemia, symptoms suggestive of malignancy, for any family history of hypercalcemia, and review medications. For example, if the person is on a thiazide diuretic or calcium, vitamin D or vitamin A supplements, then we should consider stopping these and repeating the calcium after 3 weeks. If the person is on lithium, then we should first liaise with their mental health team. Examination may be completely normal, but remember to assess hydration status, look for cognitive impairment, and then, depending on their symptoms and past medical history, a more targeted examination can be done. Further investigations should include checking PTH and the corrected calcium at the same time, and checking magnesium, as low levels of magnesium can stimulate PTH secretion. It's also useful to check a vitamin D level, as vitamin D toxicity increases the amount of calcium which is absorbed from food, and also to check for vitamin D deficiency, which is common in primary hyperparathyroidism, as the body intentionally lowers vitamin D storage to limit intestinal calcium absorption. To also check for other underlying causes, such as myeloma. It's also useful to do a full blood count, U&Es, LFTs, thyroid function tests, ESR, CRP, and serum and urine protein electrophoresis. Other tests to consider include cortisol, as Addison's disease is a rare cause of hypercalcemia, an ACR to assess renal function, especially if there's been a drop in EGFR, a chest X-ray to look for malignancies, sarcoidosis and tuberculosis, and an ECG to assess cardiac risk. If a known condition is suspected to be the cause, then we should liaise with the relevant specialist managing the person's care. If primary hyperparathyroidism is the most likely diagnosis, or if no specific cause is identifiable, then we should refer to an endocrinologist. If the patient has a known malignancy, then we should liaise with the person's oncologist or palliative care specialist if the patient wishes for further management. Remember that treating hypercalcemia in palliative patients can quickly reverse distressing symptoms. Next, let's focus on step 4, which looks at specialist assessment and management. Initial management of moderate to severe hypercalcemia in hospital, where primary hyperparathyroidism isn't suspected, usually involves contacting the relevant team involved in the patient's care, rehydration with IV fluids, and IV bisphosphonates or calcitonin. In cases where primary hyperparathyroidism is suspected, further investigations may include a 24-hour urine collection for calcium and creatinine excretion, or genetic testing to check for familial hypocalciuric hypercalcemia. If an abnormal parathyroid gland is suspected, then a neck ultrasound scan, CT scan, or technetium scan may be performed with or without a biopsy. In cases of primary hyperparathyroidism, parathyroidectomy has a cure rate of over 95% and a very low recurrence rate of under 2% for people with a solitary adenoma. For those where surgery is declined, contraindicated or failed, medical management includes calcium-lowering therapy with the calcimimetic drug sinucalcit, bisphosphonates, and cautious vitamin D supplementation. It's also important to check for complications relating to hypercalcemia, and this usually includes a renal ultrasound scan for renal stones and a DEXA scan for osteoporosis. This then leads us on to step 5, follow-up in primary care. If a person has had a confirmed diagnosis of primary hyperparathyroidism and has not had parathyroid surgery or whose surgery has not been successful, then we should arrange monitoring of serum calcium, vitamin D and Usinase every 12 months. We should also monitor bone mineral density by DEXA every 2 years or so, depending on specialist advice. We should also consider arranging an X-ray or vertebral fracture assessment of the spine if clinically indicated, for example, if there is height loss or back pain. A renal ultrasound scan is needed if renal stones are suspected, and a cardiovascular risk assessment with a Q-risk score is useful. We should also consider a re-referral to endocrinology if symptoms develop, if the calcium level increases, especially if the adjusted serum calcium is 2.85 or more, or if complications develop. If a person has had successful parathyroid surgery for primary hyperparathyroidism, then we should check their calcium levels annually and follow specialist advice about monitoring any complications such as osteoporosis or renal stones. If a person has a known malignancy-associated hypercalcemia, then we should monitor for any symptoms of hypercalcemia and arrange monitoring of serum calcium and Usinase, the frequency depending on specialist advice and clinical judgment. If the underlying cancer is not actively treated, hypercalcemia usually returns 1 to 4 weeks after calcium-lowering treatment has been given. We should also liaise with the person's oncologist or palliative care specialist as needed. For all people with hypercalcemia, we can offer advice on maintaining adequate hydration, ensuring the person is vitamin D replete, but note that vitamin D supplementation should be given with caution, ensuring that the person has sufficient but not excessive dietary calcium intake, encouraging mobilization where possible, and avoiding any medication or supplements that can cause or worsen hypercalcemia, such as thiazide diuretics and antacids containing calcium. Right, now time to check your knowledge with a few questions. Question 1. John comes to see you with a 6-month history of constipation and poor appetite. Would you check his calcium level? The answer is yes. Remember, groans in the Hypercalcemia Aid Memoir is for digestive symptoms. Question 2. John is found to have a persistently raised corrected calcium level of 2.9 on 2 blood tests. His PTH is checked and it is in the normal range. Are John's results consistent with a diagnosis of primary hyperparathyroidism? The answer is yes. PTH should be low in the presence of a raised calcium, and the fact that it isn't suggests a PTH-mediated cause to his hypercalcemia, such as primary hyperparathyroidism or familial hypocalciuric hypercalcemia. Question 3. John has successful parathyroid surgery for primary hyperparathyroidism, and his calcium levels return to normal. Does he need any further monitoring? The answer is yes. His calcium levels should be checked annually, and we should follow any specialist advice with regards to monitoring any complications such as osteoporosis or renal stones. Well done to those of you who got all 3 questions correct. And this brings us to the end of this podcast. Thank you all for listening today. I hope that you found this podcast helpful and that you've learned a few extra nuggets of information. Feel free to get in touch via social media at GPnotebook or email support@gpnotebook.com if you have any questions, comments, or ideas for future podcasts. Right, quite fancy a glass of milk now. Goodbye.